to remember. They all start by CTO and they have a number. So I'll try to get things in order. So I'll start with 1 and finish with 5. That should be good. But the first talk is a bit different. In the title, we have probably an order of the best or worst publication in the world of CTO-PCI. I would like to have our good friend Lorenzo Azzalini, and thank you for to come and entertain us a bit about what's new and what we should have seen in the literature.
Thank you, Stephane. So let's get started. There's a lot to cover. I'm gonna go quite fast. So, like last year, my talk is going to be divided in 4 sections: outcome data, publication risk scores, techniques, and miscellanea. So, outcome data. This is a large cohort of patients from central Denmark, inclusion period of 10 years, and they compare successful and unsuccessful CTO-PCI versus non-CTO-PCI, and they saw that successful CTO-PCI is associated with similar mortality to non-CTO-PCI, whereas unsuccessful recanalization leads to acute and long-term, higher rate of acute and long-term mortality. The important thing is that regardless if you have a CTO or not, in the top right corner of the slide, a complete revascularization leads to equal outcomes in both CTO and non-CTO patients. Similar study from NCDR, CathPCI registry, 500,000 patients linked to Medicare claims. They saw that CTO-PCI is associated with higher risk of in-hospital MACE compared to high-risk non-CTO-PCI, and the latter was defined as atherectomy, unprotected left main, and SVG-PCI. However, during follow-up, the balance flips because CTO-PCI is associated with lower risk of readmission in MACE on follow-up. So again, the procedure complication are the Achilles heel of the intervention, but then the patient will enjoy an easier ride on the long term. Sub-study of Renovate Complex PCI to randomized patients, all comers undergoing PCI, to either angiography or imaging guidance with either OCT or IVUS. The impact of imaging in CTO-PCI is even higher, as you can see, than in non-CTO-PCI, so the difference between the two groups is even larger. However, imaging does not work by intention to treat, like we saw in one of the earlier sessions, so that the results of imaging-guided PCI with non-optimal results is halfway between angio-guided PCI and imaging-guided PCI with optimal results. So we should aim for an optimal result and confirm it on IVUS. Our group published this year the experience in contemporary CTO-PCI with the old-fashioned CARD technique. 7.5% of retrograde CTO-PCIs use CARD nowadays in our center. Almost 70% of patients post-CABG, very high complexity, mean JCTO score 3.6. Very high baseline risk of complication due to both angiographic and clinical factors. However, the procedure had a very high success rate, 73% of CARD success and overall success of 82%, with very reasonable rate of complication, MACE 2.2%. So should not forget CARD in impenetrable CTOs from antegrade, fail reverse CARD, ortho-osteal occlusion, or if there is a lot of tortuosity that hampers our guidewire manipulation from retrograde. From Progress CTO, analysis of patient taking ranolazine. So 15% of patients in Progress who undergo CTO-PCI are on ranolazine. These patients see higher mortality and they have a higher comorbidity burden and anatomic complexity, and for this reason, they suffer lower procedure success and higher rate of MACE on follow-up, and this difference persisted also on adjusted analysis. So it's not that we should not use a ranolazine, obviously, in these patients. It's just a marker of increased complexity. Again, from Progress, retrograde CTO-PCI via ipsilateral epicardial collaterals, 4.3% of retrograde cases, 50% of wiring success. Success of the procedure is similar between retrograde through other collaterals and these collaterals. However, the complication rate is much higher, up to 3-fold higher, 3 versus 1% risk of tamponade, so we should avoid this collateral if possible. Interesting data from Amsterdam, single center study on the same day discharge after a CTO PCI. 62% of their almost 1,000 patient cohort, 7 or 8 French guides from femoral were used in basically all cases. Predictors of keeping the patient hospitalized were access site bleeding and vascular complication. Same day discharge was not a predictor of MACE, a 30-day follow-up. We wrote an editorial suggesting criteria for same day discharge. So, of course, no procedural complication, absence of severe CKD, so we don't have to monitor strictly for AKI, no access site bleeding or vascular complication in the first 6 hours of post-PCI observation, patent hemostasis, liberal use of vascular corrosive devices, early ambulation, and also very important, the patient must live within 30-minute drive from the hospital or at least stay overnight in a hotel. Again, from Progress, geographic diversity in CTO PCI, CTOs are tougher in America, as many of us knew. So higher comorbidities and higher CTO lesion complexity, higher use of ADR and retrograde approach, but lower contrast volume radiation dose and similar success rate and MACE rates. Another paper from Progress on racial disparities. Race does not impact outcomes of CTO PCI, which is quite reassuring. Very interesting data from Columbia on myocardial bridges in CTOs. So myocardial bridging are more frequent in LAD CTOs than non-LAD, LAD non-CTOs, so 40 versus 26%. Of course, bridges make the CTO look longer on angiogram, and very important, if we stand a bridge, we will have a TLF rate that is very, very high, 26%, due to a small MSA and also compression of the bridge. So never ever stand a bridge in a CTO or a non-CTO. Risk scores, so sub-analysis of Progress on machine learning risk prediction score. So actually a machine learning algorithm to predict primary antegrade wiring success that was successful in 57% of cases. Occlusion length, ambiguity of proximal cap, interventional collaterals, and vessel diameters were the strongest predictor of achieving primary antegrade wiring success. From the Japanese CTO PCI expert registry, retrograde JCTO score, JRCTO, modest, actually reasonable C statistics. Patient with lower score had higher crossing technical success rate and decreased guide wire crossing time and procedural time. The predictors, the usual suspect, moderate severe calcification, tortuosity, collateral channel grade 0 or 1, or non-septal channels. With techniques, we published a couple case reports on the use of intracoronary snaring of the retrograde wire to solve compartment mismatch in retrograde CTO PCI in complex cases. So if you're a subintimal antegrade, we recanalize the vessel in a side branch of the distal cap. We can come from retrograde, snare the retrograde wire from antegrade, and then pull the system together to sever the dissection flap between the two. An interesting case report on the retrograde use of IVL shockwave for flash ostial ISR CTO of the right. They could externalize, but nothing would go antegrade. So with progressively bigger balloons, they were able to advance a shockwave retrogradely through epicardial collaterals, and they expanded the stent, and then they were able to successfully complete the procedure. We propose a variation of the base technique facilitated by IVL in case where conventional base fails because there is 360 degrees of calcification, like in this case. So with the shockwave, we crack the calcium, then the balloon will dissect the vessel, and a polymer jacketed wire will be able to achieve a subintimal entry. This is a variation of AFR technique called SAFER, and basically it involves a Carlino technique within the occlusion, multiple dilatation throughout the occlusion to relieve the hematoma, and then crossing with a Gladius Mongo or Gladius family of wire. Final publication, just a few ones, very, very interesting one. This job is very stressful. This is data from not patient, but doctors performing CTO PCI. CTO PCI increases heart rate and blood pressure, and actually there's proof that CTO PCI is the most stressful intervention in coronary intervention because it's even more stressful than primary PCI. The longer the procedure, the higher the heart rate. So very important to think about the well-being of the operators. That's why also we wrote a manuscript with Via Lombardi about the mindset, the growth mindset that we should establish, build a culture of continuous improvement. And here we basically outline a few books that we recommend reading to establish a thriving complex PCI and CTO PCI program. And then a global consensus recommendation on improving the safety of CTO-PCI with recommendation how to maintain the procedure as safe as possible and how to manage complications. And finally, last slide on 3 eagerly awaited trials whose method paper were published recently this year. Ischemic CTO is going to randomize patients with CTO to either medical therapy or CTO-PCI, 2 arms, one for to evaluate the superiority with regards to MACE, and another one with quality of life as an endpoint. InvestCTO will investigate the role of upfront spam in high-risk CTOs, and the START trial, whose method paper was just published this past Monday, will investigate the role of bailout star in CTO with impending failure. This is all I have. Thank you.
Thank you, Lorenzo. I think I'll open to the, I would like to present the panel, at the same time. We have Salman, Allana, Ankur, Gupta. We've got Allison Hall, Khatri, Katherine, Kunkel, and Poommipanit. So let's start with the question, Lorenzo. You gave us like a lot of a big broad, but in your opinion, what is most likely to change, or is it something, have you seen something that is practice modifying in your daily practice?
So what I most eagerly await are the results of the trials, honestly, because I think that technique-wise, the field is quite mature. There hasn't been a great advancement recently. At the moment, there are no new device like maybe 10 years ago with a Stingray. Outcome data provides a refinement of our understanding of CTO-PCI in specific subset is very important, but I think that the quantitative leap of the subspecialty will be taken after we convince also the naysayers about the value of CTO-PCI with solid randomized clinical trials. And also the InvestCTO and START trial will allow us to better understand how to use these investment procedures and when to fail with style, like we used to say. I think this is the most important area of research, in my opinion.
I'd like to ask a few questions. Rhian, are you eager to hear the result of ischemia CTO, or are you nervous about it?
I'm excited about it, but I think at the end of the day, I think I'm going to continue to do what's best for my patients, and I'm going to listen to their symptoms and if they want me to do CTO-PCI, I will do CTO-PCI.
Any other thoughts about the trial, the upcoming trial? Is there, we've seen a lot of the papers on comparing people in trials versus people who are not in trials, and all the biases of the people that are actually included in trials that sometimes do not absolutely represent the people I always remember in EuroCTO, the biggest recruiter randomized 54 patients in 6 years, while he was putting 300 CTO-PCI in the EuroCTO registry per year. So it just tells you right away where we are and what is the problem with those randomized trials. So I'm not sure I'm looking forward to the results.
Yeah, I mean, I have some insider information on ischemia CTO because I'm involved in the PhD committee of one person that is involved in the trial. So cohort B is close to finish enrollment. Cohort B is the one on quality of life. Most likely will confirm that what we already know from EuroCTO and from OpenCTO. The cohort that is struggling more with recruitment, which is the target is like I think 1,400 patients, cohort A, to show a superiority with MACE. Agree with you that also Decision CTO, EuroCTO were not representative of clinical practice. I do think that InvestCTOs and STAR trials, since we are enrolling in the latter, many of us, these are hardcore CTOs, they're all comers, so at least for a niche clinical question, whether or not investment procedure worked or not, or do not work, this is very representative of clinical practice.
Any other thoughts? STAR technique, investment procedure, name it how you want to name it. We all have like a love-hate relationship with these procedures. Any thoughts? Has anybody changed their practice based on good result, bad results, and everything? I think it's worth discussing this a bit because we're awaiting those 2 trials to come.
Sure, I have a couple comments on that. So one of the papers from last year that I was really excited read and review is Roberto Garbo's STAR 2.0 paper. I don't know if you guys are all familiar with that. So what Roberto did is a slight modification of the investment where they would star back in and then identify with IVUS where the CTO body was and stent that segment and simply balloon out the outflow to make sure that they had at least TIMI 2 to 3 flow. And at least the short-term results from Roberto's series is promising, and we've done several at the clinic now and have also been pretty excited with the results, at least acutely.
So yeah, it's hypothesis generating, and I think we have a lot to learn from, you know, those single center experience like this, as much as DCB used which is done, and there's just a recent study done in Spain actually that showed that the CTO segment remained patent longer when you would use a DCB than using a balloon for STAR procedures. So that's a new data that just was published by Ignacio Ahmad Santos. So any other thoughts about the upcoming trials? You know, the SPM for INVEST procedure is a bit different to the STAR procedure. Yeah. Maybe Lorenzo, you may want to discuss what is the difference between SPM and the STAR here in the study.
No, that's a great opportunity, yes, Stephane. So basically, first of all, SPAM trial, the INVEST CTO trial is upfront SPAM, whereas in the STAR trial, it's bailout STAR. So this is already a first difference. Second difference is that technically SPAM, you just balloon the CTO part down to the distal cap, but you don't do anything to the distal vessel first. Second, you don't inject. Whereas with STAR, we start in all major side branches, we balloon everything, we take a final picture. So we don't know yet which is better. Honestly, it's not even there is no trial comparing the two, but I think that we should not be dogmatic, and whatever comes out of the trial, we should adopt with our clinical judgment, and in the future, design further study to compare these two. But I'm hopeful that both studies will lead to meaningful result, particularly because INVEST CTO is upfront, so the procedure can take literally like 10, 20 minutes if you don't waste time on, you know, trying to go retrograde in a collateral that you will never be able to cross, and it will increase the safety of the procedure. On the other hand, if STAR trial works, it tells you that in these 5 to 10% that you cannot usually open on the first time, let's say that the success rate of the second procedure is like even 50%, then you go from 90 to 95%. And so this brings up the success rate, and you know that you can have a lower threshold for STAR probably and avoid high-risk ipsilateral epicardials like in that study that we showed. And so this is practice changing to me, probably.
Thank you, Lorenzo. We have a question in the room. Quickly, we're running a bit late.
Thank you for a nice presentation. In terms of investment procedure...
Speak closer to the mic.
Okay.
Maybe closed. Yeah.
I want to ask about the medication. In patients with investment, we commonly use dual antiplatelet therapy for the follow-up. But in some cases in our institution, for example, atrial fibrillation patients, when we brought back the patient, we saw that it's quite open. Do you mind changing the medication for antithrombotic therapy or low-dose antithrombotic therapy in these kind of patients in terms of achieving that open vessel?
Well,
do you have an idea about that?
I think it's a very good observation, something interesting, as much as anticoagulation has been proposed as something better for SVG disease or something like that. But I guess I'm not aware of any data, and so, but I think it's a good hypothesis, and I think there should be more studies on this. Thank you so much, Lorenzo. Congratulations for a daunting task. It's always difficult, and you always do it like fantastically every year after year. So thank you again so much. And we will go on with the first case. Darshan, tell us a bit more about multivessel disease in CTOs.
All right, so this is a case, and this is going to be interactive. So this was a case that I was privileged to be a part of. The first part actually takes place at Bill's Center, and then subsequently the second part also takes place at Bill's Center. I was involved with the first part, and then Kate did the second part. So this is a 61-year-old male, has typical coronary risk factors, has a family history of CAD with a father with a CABG in his 70s and a brother with PCI in his 60s. That comes into play later. But he was traveling in Hawaii and then developed decompensated heart failure. Was taken to the hospital there where an echo showed that his LVEF was about 10 to 15%. His LV was not blown out or dilated. It was 48 millimeters, and his troponins were flat. He underwent a right and a left heart cath at the institution once he was slightly more optimized. I don't have the initial films, but I'll tell you what it shows, and then you'll see the films later. But essentially, it showed distal left main disease, it showed prox-to-mid LAD disease, a CTO of the circ, and then a CTO of the right coronary artery. Now, the patient underwent a viability study to demonstrate whether or not revascularization would be in this patient's best interest. He was thought to be too high risk for CABG, given his markedly depressed LVEF. The surgeons thought he would either need an Impella 5.5 or a VAD backup because he may not come off of bypass. His father had died from complications of CABG, where his brother had PCIs, and so the patient underwent extensive diuresis and then was referred for percutaneous options for PCI. So the first thing, when he was referred for the intervention, he underwent a right heart cath. So this is the right heart cath. The RA is 10, the RV is 40/9. The mean PA is 23, the wedge is 14, the PA sat is 59%. His output and index, so his output is 3.8 and his index is borderline/low at 1.9. So he obviously has multivessel disease, is going to need revascularization. So based on these hemodynamics, an Impella CP was placed and then PCI was performed. So I'm going to show you the angiography here. This is dual angiography where you get a flavor of the right system plus the left system. Okay, so again, he's got a CTO of the circ, CTO of the right coronary, has severe distal left main disease, and has prox-LAD disease. So I'm just going to let this play for a few more seconds because then I want to turn it to the panel and maybe to the audience to figure out, A, what vessels would you tackle first, and B, based on which vessels you're going to choose, what are going to be your crossing strategies, and sort of any anatomic issues that you think you may have to deal with. So maybe I'll stop there and turn it to the panel.
Katherine, any thoughts on this case? How would you approach multivessel disease when you're committed to? Are you going to do the non-CTO PCI first? Are you going to do the CTO PCI first? There's two CTOs, which one you choose? And just give.
Yeah, so in general, when I'm taking this sort of strategy, I'm going to do the left system in one sitting and usually the right in a second sitting. And so the decision to decide which one is first is generally, what's going to help the patient more acutely, and then what are the anatomic characteristics of it. I'm not quite sure what the proximal circ looks like, but I think the LAD looks pretty straightforward, and it would be really nice to get, especially since you've gone to the effort of putting in an Impella, to knock out the left system on day one.
Allison?
Just to answer your question, sorry, I don't have the films, but the circ CTO is a JCTO of 0 with a short length, just FYI.
Okay, that's good to know. So a lot of things to tease out in this case, and I think about it too, like relative to my own practice and my own center as well, where I don't have Impella. So I think the fact that you have that support in there is probably going to play some influence on how much you're willing to do in one setting and how much you think the patient can tolerate. So I tend to agree with Katherine that maybe you're going to start off by tackling the left system, because one of your goals is to try to get them out of the more acute trouble as well, and that's probably driven a lot by the left main LAD. And again, you just mentioned the circ is relatively straightforward, so maybe getting that done and potentially looking at a staged procedure on the right, depending on how the rest of the case goes.
Paul?
Especially in this situation where you have a left main that you need to deal with, I tend to try to get the left system done first because I think it probably benefits the patient most. And then depending on how the case goes, you can try and tackle the right system, or you can bring them back and stage it as another procedure.
Jay?
Honestly, if I was going to do this, I would probably try to do it all because I put the Impella in, especially if you say the circ is a JCTO 0, I would probably try to get this all done in one sitting, if possible.
Salman?
Yeah, I agree. I think I would do the left system first, just because we're putting an impella, you have to relieve the maximum amount of ischemia as much as possible for the first time. So I would go for the left system first.
Ankur?
So in these low EF patients, even though he's optimized, the more multi-vessel ischemia we create, they may decompensate again. So I personally do only one vessel or two vessels. In this case, left main to LAD provides the most bang for the buck. If the circ is really simple, easy, and very quick, maybe the circ at the same time. But
Even on an impella?
even with the impella, because I think it provides a false sense of security over the next few days. So at Henry Ford, we showed that in these low EF patients, every single vessel PCI decreases their CPO by 0.1. So if we do 3 vessels PCI, it can really decrease the CPO, and we may have longer time on impella in the hospital, more lactic acidosis and all that.
And Rhian, any thoughts?
I agree with what's been already said by the panel. I think starting with the left system is great. If things go really smooth and your pulmonary pressures haven't changed much, your output's still looking good with the impella in place, it's not a bad idea to do some work on the right at a minimum, maybe just get flow going and then get them off the table.
You know, I think every comment was very well taken. I always teach a fellow, like, go with the flow. I think when you are, and you have to analyze your coronary interdependence. If the right is heavily dependent on the left, so anything that would happen on the left on the LAD would be could be very dramatic, whereas the circ is a much lower risk, any intervention. So I like to analyze that, like if there's any TME2 flow, you should restore that. If you have a donor artery and you'll have to go through this to go retrograde, you have to do it. So I mean, you have to walk back and discuss and think about all these issues. To me, I think the lower hanging fruit that's going to provide you more support for the rest of your procedure is to start with the circ and tackle your left main, and then afterward go. That would have been how I would have done it.
Yeah, so the comments of the panel are very similar to the ones that we thought of. So a couple of things. One, to Ankur's comment, I think that when you do multi-vessel CTO PCI, we know that the outcomes are worse. So Manos has published, the progress registry, and specifically shown that if you do a second CTO, that the outcomes tend to be worse. Again, not for every case, but that's the first thing. The second thing is this guy has an EF of 10%. He has an impella, but if he's ischemic in all 3 territories, he may not be able to come off as readily if we only take care of either the left or the right. So ultimately, we decided that we were going to take care of the left system. And so in doing so, what we did was, again, we'll play this, and the thought was that we were going to take care of the circ, and here, Katherine, you can sort of see the circ. The circ is a little bit more straightforward. So the thought was, well, if we are just going to do the left main into the LAD, it may make it difficult to come back for the circ, given that it's a straightforward intervention. Probably we'll go with AWE. The thought was to take care of the circ plus do the left and then subsequently go from there. Now there is some calcium, and so we were prepared if we had to do some form of atherectomy, but the circ wired fairly easy with a low polymer jacketed wire. So it went through with the Mongo, which you see no issues. Now we have secured the circ and we have the LAD. So now the next question I have for you is, after you've secured the CTO, and there's distal left main, there's circ disease, and there's prox LAD disease, what would be your stenting strategy at this point?
Any thoughts? Someone wants to jump in?
I would probably T-stent it. I think the angles are favorable that you can stent the circ and then do left main into the LAD.
I think you need the IVUS here, right? Just to see a bit, like you want to know if this is very calcified and what you're going to do. Doesn't look like very bad. I think just ballooning and stenting is what you need to do next, but IVUS will at least rule out any wrong, something that would be surprising here.
Yeah, so essentially that's what we did. So we wired into both IVUS and basically found that the way to possibly do this would be an upfront 2-stent strategy, just given the fact that there was Medina 111 disease, and the thought was to do a DK crush. Now the question is, which is going to be the parent and which is going to be the donor vessel, the child vessel. And so the thought was, because we got through a CTO, you don't want to give up the circ, so we wanted to make that the parent. The other part is sometimes with circs, they're retroflex. And in order to actually get into this, we actually had to use the supercross, so we didn't want to give up wire position. So the thought was to do a DK crush, but use the circ as the parent and the LAD as the child. And so that's essentially what was done. And to Stephane's point, it was calcified, but it was enough where IVL would work, so atherectomy wasn't required. So again, we used IVL to basically take care of the calcium, and then subsequently performed a DK crush using the LAD as a side branch, and then the circ as the main. Ultimately, that went beautifully, no issues, no problems, and then this was the final result. Just in the interest of time, I'll go to our final picture here. All right, so this is the left system. And then at the end of this, the patient's hemodynamics were rock stable. Weaned the Impella. His cardiac output was about 3.8 to begin with. It stayed around there. And then the index went down to about 1.7, but we were able to get it out, no issues. So then the patient then came back for the RCA. I think we have a few more minutes left, but now when you see this RCA, the question is, how would you go about tackling it, and what would be the primary, secondary, and tertiary strategies you would try here based on this anatomy?
I do want to add one point. I mean, the decision for fixing the left system first was, of course, and bringing the patient back in 6 weeks, of course, for maturation of collaterals from the left to right, and that'll make the CTO PCI 6 weeks later easier. So now you have a lot of options, antegrade, retrograde.
One could also make the argument that we may have jailed off some septals because we did the LAD, so it may potentially have made it harder too, but your point is taken.
Yeah, people do get worked up about that in terms of how easy is it to re-access like that big first septal if you've stent shielded it, because that seems to be like the primary avenue for your retrograde. But panel, have you guys had issues with re-access? I mean, I've not really honestly thought that was a big deal. It seems like more of an urban legend than an actual reality.
The only downside is I've had issues with even. It's more like old stents and new stents. It's been recent, it's okay, but you can have issues with entrapped microcatheter through the strut, so it's not a bad practice to balloon it with a 1.5 and go down and just not embark into something that's gonna be super heavy, complex with things, and then realizing at the end that you have an entrapped microcatheter. So my practice is always to balloon it, and then when I'm out, then I re-balloon the main.
Did you guys do that, Darsh? Because I saw a wire in your completion intro.
Yeah, so that was actually very astute. So I protected it while stenting it. I remember asking the panel, and they said, don't worry about it, you'll be able to get back in if the wire's there. And sure enough, as you'll see, we're able to get back in. I think my practice is, if I can not stent jail the septals, obviously that would be ideal if I'm going to use that as a retrograde conduit. And particularly if they come off at a very acute angle where it's going to be difficult to wire. Once you put a stent through and now you have an acute angle that you have to now tackle, it can become challenging. So, but here, our primary strategy was to go with antegrade wire escalation, and then it's dealer's choice. You could have done ADR distally. There seems to be a good landing zone before the BIF, or gone retrograde. And ultimately, this was Kate doing it. She went retrograde. She went antegrade, but it went subintimal pretty quickly. So instead of spending hours trying to rewire, went retrograde. Was able to get through a septal. The first septal actually was like a fake-out branch that didn't really connect into the PDA appropriately. Then found another septal sub-branch, was able to get it done. Reverse cart was done. And then ultimately, no issues, except the fact that there was a mild distal edge hematoma. And so, with the panel, would you have tackled the distal edge hematoma, or would you just leave it alone?
I think those are sometimes what you can leave alone. You can sometimes take a small cutting balloon down there, do some balloon massage, give some nitro. So you have options. I wouldn't ideally take a stent more into past that bifurcation. Just let it plump up with time.
I think IVUS is the answer. When you see it by IVUS, is you.
But if you have TIMI3 flow, why do you need to do anything here?
I have a question for the panel and maybe audience. So here, most of the RV marginals are lost. So in your experience, we often lose them, don't worry about them. Do you have any thoughts on when losing the RV marginals do not really affect the RV function versus when they do?
Well, there's one thing I think for RV marginals. losing them acutely, if they were patent to start and you lose them, the patient can be very sick. They can VF overnight, they can do a lot of things. So of course this patient is not a same-day discharge type of patient, but don't let these go. RVs are very resistant to ischemia. They recuperate, but they're usually on the long term, you know, ischemic cardiomyopathy by definition has a normal RV. So it's because RVs recuperate, right? So they usually don't tolerate acute, but if they tolerate acute, you're fine. But again, here I think it's worth preserving them, especially if you have a patient who has a low EF and everything. So maybe in this case, I would have decided to go retrograde as a primary and try not to dissect as long, but you know, it's a discussion.
Yeah, I mean, obviously, if it's a very large, dominant RV marginal, you're going to try to protect that at all costs, and it obviously plays a decision when trying to use an ADR strategy versus a non-ADR strategy, dissection reentry, even if it's retrograde. I've had a case where I had a patient where there were 3 small RV marginals, did it easily with ADR, chopped off the 3 small RV marginals, not super dominant, and the patient went from having no TR to severe TR. And so, again, I don't know if there's a good answer as to when to preserve it. I think a good rule of thumb is if it's definitely greater than a 2.5 vessel, then obviously you should try to preserve it. And then even 2Os, if it's a large, long vessel, I'll still try to protect it, and that's been my strategy.
Please conclude, Darsh. I think we're running a bit.
All right, thank you so much.
We're good? Thank you. Thank you so much. Very good case. Again, we're going to go on with, this time it's going to be Katherine. She's assigned to number 2. Topic 2.
CTO number 2.
A case.
A case. So this is a case from right when I started my job. So fresh out of my CTO training. So this is an 82-year-old gentleman. He came in with NSTEMI, so I picked him up as the doc of the day doing diagnostic casts. But when you talk to him a little more, it turns out he was a preacher up in the mountains of North Georgia. He liked to do a lot of farming and was actually taking nitro mid-sermon for the last year. So he's been having a lot of angina that he's just been dealing with, and we find this a lot in our patients. He has an ischemic cardiomyopathy with an EF of 30%, the usual risk factors. And so here's some diagnostic angiograms. And you'll notice here a pretty target-rich environment. So, you know, the exact thing you want to see when you're a brand new faculty member, lots of blocked vessels. So we've got an OM, a RAMUS, an RCA CTO, and then this LAD CTO that has several branches attached to it. So the patient underwent cardiac MRI. He had viability in all territories. He was turned down for CABG due to his age and comorbidities. And so I guess I would pause there and ask the panel, where would you start? What would your strategy be? And how much do you need to do for an 82-year-old? Is this a complete revasc patient? He's not 65 like our previous patient.
You did the MRI for viability. Do we have a functional study show I mean, for ischemia? Does he have like inducible ischemia somewhere, more, whatever?
No.
No. Anyone want to take it?
He had some troponins. I don't know where they came from. There are lots of candidates.
I think with his age and his comorbidities, my thought would be to try to be as minimalist about this as possible. So I'd be shooting for anterior wall revasc, if technically feasible, and just see how he does clinically.
I would tend to agree with that as well. I'd go for the likely larger territory of ischemia, which is probably going to be his LAD. That being said, it's a little difficult to answer this without looking more carefully at the films, at the exact difficulty of each of the vessels, and whether that would change the order in which you do things. But otherwise, I would say LAD revasc first, probably.
Then not all 82s are, the same. We have in Scottsdale 82s who are hiking, biking, doing marathons versus 70-year-olds who are not doing. So it also depends on the frailty and the activeness of the patient.
Yeah, and so this is like a preacher. He's still getting up there despite the nitro. He's still trying to work in his fields as much as possible. So, he's a pretty robust guy. So my strategy here was I was going to try to do as much as I could safely do, but choose strategies that really focused on getting the most bang for my buck while focusing on safety too. So I agreed. I thought that LAD would be my first target, biggest bang for your buck, and a relatively easy CTO. my biggest thought on looking carefully at the LAD was I've got a lot of side branches and they're pretty large, and they're right at the proximal and the distal cap. So, one of my concerns going into the LAD CTO is how hard am I going to fight for all of these side branches? And ideally, I would have liked to clean up the left side. I don't know if you notice on if it came over, but there really wasn't a ton of calcium. And so that was the one thing working in my favor. And then my plan was to break at that point in time and come back for the more challenging CTO. And if I had anything else that needed to be cleaned up, clean it up at that time. So here you can see I'm setting up for the LAD CTO. I did get dual access without any intention of using the RCA as a retrograde conduit, but for potential visualization of the distal LAD. And sure enough, I was able to pretty easily cross the LAD CTO using a polymer jacketed wire. And then after ballooning and securing that first diagonal, you say, oh, actually there's another one that's pretty large coming in from the body of the CTO, right close to the distal cap. So fortunately, I was able to wire that also with another polymer jacketed wire and ended up with kind of this sort of anatomy. And so, the question to me came, how am I going to handle stenting this? So I have two very large diagonals kind of with the CTO body, all kind of in the same area. Any thoughts on a stenting strategy for this guy? I did something a little weird.
I think provisional is always the best way. I mean, by IVUS, I guess it would help you figure out how bad the osteums are. Sometimes I just wire protect, do provisional, and then if I have to do a rescue tap or something afterwards, I think sometimes that's more ideal for these side branches. I'm really a proponent of, those small bifurcations. Sometimes less metal is better.
Yeah, I tend to agree, and especially in an 82-year-old with this degree of disease, I try really hard to do a provisional approach, if you could at all do it.
Yeah, and the presence of DEBs in the market now may also help change that a little bit, when we can use them for non-ISR lesions.
Yeah, I think the thing I was thinking mostly is that at various points in this case, I had no flow in either branch, and I think that's something that really sways me a lot with diagonals, is if I completely lose flow just with balloons at some point in time during the procedure, I think those vessels, if you care to have them open, they tend to need metal. So I did kind of a double culotte, a double cascading culotte. I don't know that this technique has a name, but after ballooning the LAD, I stented and then optimized and potted in the LAD from D2 into the LAD, D1 into the LAD, and then after kind of ballooning and rewiring through both, deployed one stent. So kind of two culottes with one stent through the LAD. And the hardest part of this procedure by far was not the CTO, but it was actually rewiring D1. That took a fair amount of time. But after 2 rounds of kissing balloons, I got a result that I was pretty happy with. I was tired, so that was round 1. So I did end up bringing the patient back for round 2 and focused on the RCA now. And again, keeping in mind we've got a pretty robust patient, but I thought I had a relatively short occlusion here. I thought there were islands of contrast going back more proximally. So I ended up wiring this antegrade just with a polymer jacketed wire and a microcatheter. And kind of here's a moment that I might have done differently now. But kind of after this, after ballooning, you'll see here as I position my stent, I've got a nice long dissection. And I think now I probably would have pulled that stent back about 10 millimeters. But ultimately, with that nice healthy dissection down there, I stented and I lost my PL. So what would anyone do here? Would you have made a different choice? Would you perhaps considered going retrograde or left it as a star? All things that I could have done differently.
Did you IVUS before stenting at this moment when you had like were there anything that could predict that you could lose the PL?
Yes, I was in a dissection flap.
Okay.
Yeah. So, I think I had myself talked into that I could rewire this, and I think that's something that I struggle with is kind of getting this. I think I did briefly try to rewire the PLs using a Gaia to kind of scratch in, and also with a Mongo, and was unable to get into the PL and just ended up sacrificing it.
Was the patient symptomatic at this time?
Nope, he was rock solid.
Any other thoughts? Anybody here who would have in the panel, who would have tackled the circ OM first, or in those who votes for circ OM first and leave the CTO for later because of the age, versus B, tackling the right and doing the circ later or whatever. So who votes for the circ first? I would like to see.
But what about, Katherine, how did he do after the LED? Did you see him in follow-up? I mean, or did you just set him up for the staged procedure?
He was just set up for staged.
See, that's the one thing that, I think that with him, I would be curious to see, you did such a great job on that anterior wall, and that might have been enough for him.
Yeah.
I probably would have done a couple things. I probably would have seen him follow up and see how he did. I mean, you're basically trying to improve symptoms in this 82-year-old. If you can get on the preaching stand and preach, I might have said that was enough. I think the second thing is I'd probably go after the circ first. It looks more straightforward than trying to do the RCA CTO.
And it maybe look a bit more like potentially vulnerable over the next few, whatever. I mean, it's a long plaque. It looks like something that maybe could be worth doing. And then so finally you did it.
I did it at the same time as the RCA CTO. When I knew that I was going to be doing the circ, the ramus, and the RCA, and I think I thought anatomically it didn't make a difference for the patient which one I did first, and psychologically for me, I wanted to do the hard thing first. So that's why with it, but I knew in that procedure I was going to be doing those 3 vessels.
I agree too, and I think that's kind of the beauty of what we do, right? There's no right way of doing it, so I think whatever works in your mind, and I know when you have a complicated or difficult vessel to treat, I'd rather get that out of my way, so then the easier one is like something I can do when maybe my alertness is not as high.
I agree that there's a lot of dealer's choice involved in this because you don't know which one particular territory is actually causing this guy's symptoms. Presumably the LED was a big player, but I mean, beyond that, you just don't even know. So I think there's lots of ways to do this. Safety has a factor in, I guess, too.
Yeah, so this circ was straightforward, IVUS-guided PCI. The one other procedural decision-making thing that I spent a long time looking at this film before going in is this ramus was quite large. If you saw it as an OM in an ideal projection, it's got to be 20% of the myocardium. So I did decide that I wanted to treat this very tight proximal ramus, but spent a long time thinking, well, should I bring it into the left main? Do I do a tris here, with my distal left main? And ultimately thought, I think the thing here is to just keep it simple. And so I just did kind of, not even really technically V-stenting, I guess, in that area, and got what looked on IVUS and angiographically like a pretty nice result in that ramus additionally. So this is the final for that patient. And he's done very well. Back to preaching, back to farming, EF's a little better. I think the takeaway point for me is I didn't realize kind of where my pain point was going to be in that LED procedure. I did less than I thought I would do at that time. So I think keeping flexibility in your plan, not being dogmatic about I must treat everything in one procedure was important to me. And I did go into this case saying this is a minimum of 2 procedures. And I think especially when we have patients traveling from far away for complex coronary procedures, managing those expectations from the beginning is really important.
Thank you, Katherine. Vlad, you've got a question?
Yeah, well, comment.
Comments,
yeah. I mean, with respect to dealer's choice, you have a large vessel here with big territory, right branching, big branching OM. So one could have argued to do that first, but it's probably 6 one, half dozen the other. My question is, did you pull the wire from the PL before you stented over it, or did you have a wire in the PL?
I was unable to, so I tried to get a wire. So I was in a dissection flap going into the PDA, and this is one skill, the number one skill that I want to be better at and I'm working on is when I'm in a dissection across a vessel I think it's hard, to use a more penetrative wire, to try some more polymer jacketed heavier wires, but to find that vessel to restar back in, I think is hard. And so I tried and I was unsuccessful.
I think your retrospective idea of stenting just prior to the crux could keep that vessel open. In fact, may open up entry into that PL and then allow you to do both. And if you need to stent distal to that, you still can later on. It's hard retrospectively, but yeah.
Katherine, you think your RCA, your first wire spiraled around the artery and then re-entered distally beyond the crux? That's what you think happened there?
Yeah.
So one thing that really is helpful
Although
in these
it
scenarios.
wasn't knuckled.
Huh?
It was not knuckled, which
Yeah,
was
no, it
interesting.
just happens.
Yeah.
It can happen. But one thing that I've had a lot of luck with in these scenarios is put a Boston IVUS down, a dual lumen on the same wire, abutted into the IVUS, figure out where you went sub, and then rewire. And you can see it in real time, and it's a reliable way to do this and have control of both branches.
It was a very interesting case. Any other comments regarding the sequence? I think I'm leaning also towards maybe doing a bit less given the age, but it also depends. You don't want to be doing ageism. It depends on the patient, right? If the patient is very active and feel that everything has been like very short time and he's not able to play tennis anymore. These are things that come in your mind where you want to do more, but if he's rocking in his chair all day, I don't think I would have done more than the LED, but that's, I don't know what the others think.
I'm a minimalist. It doesn't sound like he had an ACS as a chronic stable angina.
He was an NSTEMI when he came in.
What's that?
NSTEMI.
You had an NSTEMI? Oh, well, then I think I would have been a little bit more aggressive the way that you had done it. But if you'd been a chronic stable patient, then I would have just done the anterior wall and called it a day. But I think I missed that whole point of your presentation.
I think we agree. With a non-STEMI, I would have at least done everything on the left system, but maybe not the CTO. That's basically what I would have selected to do, and then keep the CTO, let's say, if he's coming and still is. In trials, you would have had to do all the non-CTO stuff first, right? If it'd been randomized into, let's say.
I struggle with this. I struggle with finding the balance of aggressive enough. You know, he's super active. Don't be ageist. If he got a cabbage, he'd be getting everything done. Versus, well, maybe I can be selective in my techniques and accept losing a PL and not go retrograde, you know, or do that sort of thing. So I think I'm still in my clinical practice working on finding what is the right balance there.
I think once you got past the first procedure and you knew you weren't going to do anything else on the left side and you knew he's coming back for a second case, I think you did everything appropriately. I probably would have done a little different sequence because I like victories first before I start the hard stuff, but I think to each their own. And you got a great outcome, so.
Just one point, Katherine, with the right coronary artery angiogram, the one thing that's always been humbling to me is that those islands of contrast that come in. You know, you feel that, you know, those lesions, I would be able to cross it, and then those islands of calcium are actually the most, where you would be ending into dissection planes. And there was a paper on it too, that those are bad markers for CTO crossing.
So thank you, and let's thank you, Katherine. Let's move to our next speaker, who's going to be Perwaiz Meraj, who's going to be presenting CTO3. And, you know, just a comment regarding if the surgeon would have grafted, he would have grafted everything. Well, surgeons only have one shot, right? We have the luxury to be able to come back, and that's something that we have to learn and maybe be more.
They were being ageist. They wouldn't operate.
There you go.
But what I will tell you is nowadays the surgeons aren't always going after everything, right?
Yeah, they're selective as well.
They're being more selective. There are, at least in my institution, there are surgeons who will do minimally invasive cabbage. There are people who do all pump, so they don't necessarily go after everything nowadays. So.
And I mean, data from the PRAG-4 trial from the early 2000s showed that, you know, we put vein graft to these CTO lesions and their success rate is about, a patency rate at 1 year is about 25-26%.
Yeah, that's one of the reasons why they're not chasing CTOs most of the time. We don't want to take up too much of your time. Go ahead.
No, thank you. This is a great discussion, and I think we can continue some of it in this case. So thank you for the invitation. No disclosures. My disclosure slide was missing there. Interesting case, 44-year-old gentleman, young, so we'll go in the opposite end of the spectrum. Type 2 diabetes, hypertension, hyperlipidemia, and I think this last line is probably the most important. Prior MIs, 2 STEMIs, one in 2013 and one in 2015. The first in 2013 was an LAD anterior wall with reasonable recovery of his LV function and RCA. And I'm going to actually show you the two films from then too, which I think are important to see. So this is you can see the aneurysmal RC on the left of your screen. Not surprising that that caused a STEMI a few years later. And on the right, you can see here, that's the post-procedural LAD. The operator put a 3.0 and a 2.5 Resolute Onyx stent at the time. And all of this is going to come back in a minute. So he presents with unstable angina, makes some cheap enzymes, and was cast for a non-STEMI. And this was not my case, but this was a case that before the operator sent it to me, got this anatomy and of course tried to open up this LAD CTO. So I'm just going to show you this LAD CTO, if you can see it over there. And I don't want to give away too much more, but the question becomes is, they were unsuccessful, and then they referred it to us at the main hospital. And I'm just going to show you, these are two pictures, just so you can see them more carefully what the CTO looks like, and I will stop talking. I'm curious what everybody would do, how they would tackle it, what do you think the issue is, what's going on there in that LAD, etc.
Any thoughts here? First, he's 44, and I'm struck by the multiple aneurysm, and I'm wondering if this patient was a Kawasaki when he was young. This is typical anatomy of a Kawasaki syndrome. So it must, and they're known to have subsequent coronary artery disease like this. So I think it may have an impact on what we're going to do, because sizing may become an issue. It's difficult to find 8mm drug-eluting stents for coronary, so.
Perwaiz, do you know if they use intravascular imaging for the index procedure? I'm just wondering about sizing of these stents to begin with. That seems kind of small.
You're absolutely correct. They did not use intravascular imaging, and yes, you'll find out how small the stents are.
And although he's 44, given the fact that it's a stent failure, given the fact that he's got good targets and everything, I think you need, if you can have a complete arterial revasc by a top coronary surgeon, you might want to consider that, because you're already dealing with a first failure on an LAD. So I think it would have been my first step to do. It's better to lose one and gain 10 after than doing someone that maybe not your best candidate. But again, I think it looks like, I don't know if it looks like an ipsilateral collateral that comes from that, around that, the take off the LAD right there, the septal. It seems it's a very strange anatomy. Any other thoughts?
So I have a thought. I'm stealing the thunder though, go ahead. No. So to me this is basically recanalized thrombus. And to me what this looks like is you had an ectatic segment, undersized stent thrombosed off, aneurysm thrombosed off, and then this channel formed around that stent and perhaps into the stent. And only because I've seen this once or twice, but this kind of this serpiginous kind of route, and I think when you do IVUS, you'll see whether you're within the adventitia or not. And what's impressive is that they've got multiple sites of ectasia, and even on the circumflex, the disease has progressed, because whenever the diagnostic was done, the circumflex looked better. So I get the feeling, I don't know, but that this is organized thrombus, which is recanalized.
So you're like, I'm gonna use it, I'm gonna cross it, I'm gonna balloon it. You're not afraid. You don't think it might be a collateral, because that's what comes in my mind. If it's a thrombus recanalized, it's within the vessel structure.
Correct.
I'm going. But here, I don't know.
So you could do a CT, or you could actually cross it and gently angioplasty and see what's going on, because again, it could be a collateral, but it's an unusual collateral to form like this.
Any other thoughts?
Yeah, I mean, when I see that, I would go for a CT to exactly. I mean, you have a stent there. It looks like it's probably going through the stent, but I think CT would be really, really helpful in identifying the anatomy and making sure that, are we going to go through the stent will be okay, and are those really collaterals or recanalize the vessel?
Anybody here feeling comfortable and tracking that area, just proximal and go down?
If I did track it, then I would do careful, gentle imaging of it before I do much else. And again, you might be around the stent, and then you're looking at like crushing the stent and this giant ectatic. And to be honest, like going back to what you were saying earlier, I almost feel like in some ways a gentleman potentially would benefit from grafting just because of all these issues with ectasia and thrombus within the vessels. And I think there's progression of circ disease as well, potentially anyways, and he's diabetic as well.
At least the LED being grafted, the robotic IMA, and then you could PCI the rest, whatever.
Absolutely, great thoughts, and I think these are all the conversations we had. So when this case was referred to me, that's exactly what I said to the patient. I said, we should probably talk to one of my surgical colleagues. Not to say that we can't do this, it's just that you're 44 years old, you have diabetes, you might have Kawasaki's disease in the past, and something's going on here. And I don't know the long-term patency of anything that we're going to do. So we may do all the work, it may come out great, and then 5 years from now, it may not be so good. So he spoke to the surgeon. He did not want to have surgery. And you know, we were not doing mid-cabs at the time at the institution, though there are other institutions in our area that were. He went and actually saw a mid-cab surgeon and did not want to get the mid-cab done either. So I have seen by 2 different surgeons, and then he came back to me and said, what do you think? And I said exactly what you guys are all saying. I'm not sure what this is. So I said, let me first see what's going on. And so to your point, my thought process was to do this. So this is what I was thinking. What the heck is this? So I gave my little, my little structure. That's my distal, that's my proximal. Is it bridging? Is it collateral? Is it intravascular? Is it extravascular? And I have to be honest with you, to Salman's point, that, was this all just thrombus? And this is just, it's all in the vessel. And I honestly had no clue. But as we discussed, this is what helped, right? So there's a septal there that comes off right before the CTO segment starts. So we wired the septal without touching the CTO segment at all. And I said, let's just IVUS this down into the septal and see what this looks like on the proximal cap. And you see what you're dealing with. And to your point, Jay, is like this is clearly a super undersized stent, and it's floating in the vessel. And if you look, that's where the collateral is coming from. So the collateral is actually not around the vessel. It's just within that aneurysmal segment around the stent. And the one thing that was worrying me is that if you try to go through that bottom segment and not through the stented segment, in this aneurysmal segment to crush this stent against the wall, I did not believe, and I'm curious what you all think, you're going to get a reasonably good result out of this, especially given how complex this is to begin with and how much risk there is in this not staying open in the long term. So any thoughts here before I move on and tell you what we did?
Well, the question here is this a stent that's floating in the artery and that gap is still the vessel architecture, or is that some separate bridging collateral that's grown? And I don't know if I would be able to answer that. And I would be very uncomfortable to wire that. I would want to go coaxial through the stent to make sure I'm in the vessel architecture. But it could be that all of this is the artery.
Right. I mean, I think the nice thing here is that you've got this stent to guide you. So if that collateral or intravessel around whatever wasn't there, you would have just taken a stiffer penetrative steerable wire and crossed this like any other in-stent CTO. And so my first inclination would be to kind of ignore that pathway and just cross it like I would any other in-stent CTO with a pokey wire.
Yeah, I like that. I like that idea. Any other thoughts?
Were there any septal collaterals on the right?
There were none. It's all ipsilateral collateral. It's that collateral, that serpiginous collateral that goes around the aneurysmal segment and the entire stent actually reconnects into the distal part of the stent. If you saw in the previous picture, I think I can go back.
So this is probably aneurysmal segment. If you look at that stent, the stent is about 3 millimeter based on the IVUS markers, and there is another 3 millimeter in that area behind the stent. So there is no proximity that's 6 millimeter and still plus some more. So this is probably aneurysmal segment, which kind of makes sense that this is a thrombosed aneurysm that thrombosed the stent.
So getting into these occluded stents in a floating aneurysm is so tough because that ostium is floating and the wire just keeps bouncing off and prolapse into the septal. So what you could do, which may work, is the size of that. You just take a 2.5 balloon and gently inflate to like 3 or 4 atmospheres to block it. And then you poke at the stent, and that sometimes works. But if you think in your heart that this is thrombus, if you convince yourself, then gently probing with the Mongo, because it is organized thrombus, sometimes it will just cut across and re-enter somewhere in the vicinity of the stent.
It would be nice to have some, if you were able to do even that ipsilateral, septal collateral, and get something retrograde too to kind of just give you a target. But alternatively, I don't know there's mixed thoughts out there of crushing a stent if you go through, the side struts or whatever of it. I don't.
I mean, to Rhian's point, the first septal, you could have some ipsilateral collaterals, hard to see, but there could be some ipsilateral collaterals that the first septal may be connecting into the mid-LAT.
But the problem is that you're going to get retrograde, you're going to be in an hostile environment as much. It's not less hostile. It would have been nice if it would have had a lead to the stent, but you got to be leading all the way to that thing.
Right.
And that thing scares the hell out of me.
Agreed.
I would not want to. I hope people in the room don't think that we should take it because if you're in an epicardial, it can be a disaster here. Very difficult to treat.
Exactly.
And you're going to have a huge ischemia distal, and this guy will not tolerate this.
Nope. Agreed.
So the two things I heard the safest were do a CT. I think I like the idea of the CT. And second, if you do something, try to stent. Try to stay away. Try to track the stent. Stay within the stent. You've got borders there. We've got fantastic wires. We've got Gaia wires. We've got everything. Just stay away from this and try to get it down. I would have been.
And getting coaxial with the stent's not hard with IVUS. You already have your IVUS there. I would do it with the IVUS guidance, and you could be very confident you're coaxial.
Yeah, I think I would just take a penetration wire and try to get in the stent. You have a landmark as to where you're going. Luckily for you, you have old film, so you know that it was where you wanted it to be. I would just try to do my best to go through the stent.
Right, and that did help us. The old films actually were very important in understanding this. Is just why I showed them. So yes, it was not fun. We did use it. It took a while for us to penetrate into that stented area. We did not want to go around the stent for the exact same reasons. And honestly, I just didn't know what the right answer was. I'm not going to lie, I had no clue. But I said, the safer option, in my opinion, was probably just going through the actual stent itself rather than trying to figure out what another technique. We did use we initially tried with hydrophilic wires before I tried penetrating wires. The hydrophilic wires just kept going into that other space and actually went down around the stent. So I just actually parked a wire there and just left it there so I knew what was going on. And then, as you can see here, we left that wire in the septal just to keep that as a marker. We had the IVUS there. The IVUS actually ended up not helping us. It was interesting. I don't know how, I'm sure this is a whole nother conversation we can have. In my personal experience, I haven't seen IVUS really be as helpful as I would love it to be in situations like this because it's just hard to navigate. In the end, I think we just found the right penetrating wire to get into that stented area, parked our microcatheter just into the ostium, switched out for a Mongo, and then we took the Mongo down through the stent itself and got back into the vessel. You'll see here, checked multiple views and made sure we were where we wanted to be. You'll see here, we got into a septal, which is always nice distally, so you knew you were in the vessel. And then we ended up IVUSing. I'm not going to show you the whole IVUSes, but we ended up IVUSing it. The proximal segment was a 6 millimeter aneurysmal segment. So we took a 5.0 onyx and post-dilated to 6.0. We post-dilated the other old stent as well and made that appropriately sized all the way from the distal to the proximal. You'll see the final result in a second. This is the IVUS picture with the area, insane areas there proximally. As you can see here, not surprisingly, the flow is not exactly perfect, but that's to be expected with that kind of aneurysmal segment. But reasonably is well opposed, size big, and so we'll see what happens in terms of his outcome. Now this is 3 years later, he still follows with me, and he's had no further ischemic events and no issues whatsoever. So far so good. That doesn't mean it's going to last forever, but I thought this case was really interesting, and it's actually the first time I'm presenting it at any conference because of understanding what to do with that stent in that floating space. There's no right answer in my opinion, but I was curious what you guys all thought.
It's a great case, and I think it was it's likely a Kawasaki with those dilation, and of course we don't have there's a guy in Montreal that has a big, and they have like more occlusions, they develop more CTOs, they have a lot more of this. Vlad, you have a question or a comment?
Yeah, great result. my concern would have been, and it's still small, is you had a very large vessel and distally a very small stent, and these can often be much, much larger when we interrogate them with IVUS, and depending on what stent you have, you may not have enough to get that stent to a large enough size. Even before that, I mean, how we talk to the patient about surgery, I think influences them greatly. So, you know, if you say, we can do this, but I'm going to send you to a surgeon, it sort of gives a signal that this is okay, this is good, and this is still a diabetic man, though he's gone 3 years, he's now 47. What's he going to be like at 50? What's he going to be like at 52? So just the only comments.
Of course, no, absolutely.
All right, so let's move on to our next speaker, who's going to be Rhian Davies, and she's assigned case number 4. It's a tough one. 4 is
always harder than the third one. No. All right, so I'm doing a case about STAR. I just kind of want to get an idea in the audience, how many folks here are comfortable with STAR? How many people have done STAR? Okay, so a good amount of you. My disclosures. All right, so this is a 70-year-old gentleman that presented with progressive shortness of breath and exertional chest pressure. He presented to a community hospital, so not my main hospital. He has pertinent history of hypertension, hyperlipidemia, type 2 diabetes, no prior cath, really nothing in the way of prior heart history. They did a baseline echo on him that showed an inferior wall motion abnormality, and then they decided to send him to the stress lab, and he had inferior ischemia on a PET stress. So here's some pictures of his left system. So tortuous LED and circumflex, but really nothing in the way of significant disease. But you can start to see that there's collaterals to the right. They're pretty well formed. And this is a picture of the right. And this, you know, it's always interesting what kind of pictures are going to come across when a patient gets transferred. So this is the only diagnostic picture, and then there was the picture on the right side. So you know that a couple wires, or a wire is down anyways, but the main difference is there's a loss of a lot of the collaterals, right? So you had right-to-right collaterals, and in the final picture, you don't. Did I do something there?
So the Microsoft issue is striking, but let's be hopeful.
You know, when you see those, I call that a clueless attempt, and without dual injection, without nothing, and then it's beside billing for something. I don't think there's any rational behind it. Mm-hmm. But again, it tells you that it's a CTO.
Right.
It's like people on TikTok that see a recipe, they want to make it. It's just like that. See the CTO because then I can do that.
Yeah. I agree. I think I can dance too, but TikTok dancing is a whole nother level. Yes. But these things this happens. This is like everyday sort of situations. These things can happen, and sometimes it's just awareness of knowing kind of what you're getting yourself into. Unfortunately, after the case, they got him into prep and recovery. They admitted that it was an unsuccessful attempt, but the patient developed a significant amount of chest pain. Now, sometimes maybe that's in his head because he was now told he had 100% blockage, but in all fairness to the patient, he had collaterals there that maybe now are gone, and he's just experiencing the pain as a result of that. So my partner accepted him in transfer, and then had a family emergency, so that turned to me being in the cath lab that day. So I ended up bringing him, and I had dual angiograms. Now, whenever this is sort of the situation, we try to limit, our antegrade injections, because I don't know how the patient left the lab. I only have the information that was in the cath images from the outside hospital. So I took only 2 pictures from antegrade as well as my setup from the left side. So I'll stop here. thoughts on how to kind of tackle this?
Any thoughts, Katherine, Allison? Feels like retrograde would be cool, right? I don't know.
Yeah, you've got some nice retrograde septal options. In general, this person has really tortuous vessels, which is probably going to cause you some grief along the way in either direction. But you do have nice retrograde options. I think like most cases, you're probably going to end up needing a bit of antegrade work anyhow, so if you did want to start with some antegrade work, but maybe a reasonable chance you might have to go retrograde as well. The occlusion doesn't look terribly long maybe on the dual injection, which is nice to see.
Yeah.
Retrograde is always an intention. You'd like to get there, but you don't know if you're going to get there. And you have to have a plan B, right?
So if I'm reading it correctly, it looks like there's an epicardial collateral from apical LAD2. So when I see that, I'm like, why did that develop if there were very good septal collaterals to this? So anytime I see that and these fanning septal collaterals, I'm like, there's a pretty good chance I may not be able to cross those septal collaterals. So I would be not surprised if I can cross those septals.
You think there's an epicardial? I don't think so. Well, you see.
Looks like.
I think it's a septal that comes to the mid PDA, but I don't think that the apex actually connects. But it could. There's an atrial one that is something that my good friend Kambis Mashaiki would do in a snap, but that for a lot of operators would not be the first approach, right?
So, Rhian, do you think that that's hematoma from the injection or calcium? I think it's hematoma.
I think.
And so, yeah, so I think like you are encountering a vessel that's pretty torn up to start with and has not had any time to heal. And so I think as a result of that, they probably got a fair amount of compression down there already. I think the retrograde looks pretty hard. So, I think unfortunately at this point in time, I don't see any great antegrade options. You can certainly try and get lucky, and the title of your talk is STAR. As far as doing something with a stingray, I think you've got a lot of hematoma down there already, so kind of limited options from that perspective.
Did that proximal cap change? Is that a dissection flap at the proximal cap now, or?
Yeah.
Yeah?
I think, yeah. Real life, this is kind of what I was thinking and working through stuff, but kind of all of the things that you guys mentioned were what I was thinking. This would be slam dunk if I can get retrograde.
It's too bad, actually, that they have so much ongoing symptoms, because you could leave it to heal some of that dissection and come back. But now that I see that dissection, I think the retrograde is more promising, or I think you'll tell us another way.
But you had to do this because the patient was...
When they attempted the first, how far did they go antegrade? I mean, did they cross the bifurcation, or did they not?
So outside hospital, so it's like hard to really know, and that's true story, didn't really come out. I did eventually, after the case, I actually was able to download their procedure log, and they actually used a fair amount of jacketed wires as well as sharp wires, stuff that I personally just don't do for ad hoc kind of PCI, but it's all something that I think we can all learn from. It's just, it changes your options, I think, then in the short term, what you can do. Certainly if I could let him heal, I would, but he's still on a nitro drip.
So go on and tell us a bit.
Okay. So turns out, yep, CTOs are quite humbling. I did try to get down antegrade just to get stuff kind of going in my mind, thinking at a minimum maybe I was set up for a reverse cart, really went nowhere. I did a bunch of septal surfing, and again, you can sometimes see great collaterals to go down. In my opinion, doing a case like this first time, I'm not going to tackle those epicardials. There was an apical epicardial, like you kind of pointed out there, Ankur, and as well as the atrial one, both of which I'll take on epicardials, but I tend to prefer to fail, or at least have like an unsuccessful attempt, particularly in the setting, like the first time meeting this guy and maybe him not really understanding the gravity of the risks of the procedure. So I failed doing the retrograde, and ultimately with the hematoma that was down in there, I didn't think stingray was going to be a very easy attempt, so I ended up doing STAR. Now STAR is, I think, a really good bailout strategy. It's a strategy that even outside of the CTO space, it's something that as an operator, an early career operator, you're in sometimes the middle of the night cases can get unstable quickly. You may pull your wire, have a dissection. So it's a nice bailout strategy because sometimes prepping a stingray and you haven't used one for a while might be a little bit challenging. So knowing how to kind of do this and maybe what gear you need is important. In this situation, I did a 135 Pro XS and I had a Gladius Mongo, which is a wire that's newer on the market, but it's designed to kind of do this sort of job where you see that it bends and then it will kind of jump and escalate forward, like right, boop, right there. So it goes into the PDA. You can confirm that on retrograde injection. And then, advance the microcatheter, switch out for a workhorse wire, and I ballooned with a 2.5 and a 3.0 distally, and all the way back to the proximal.
The question, where did you re-enter by IVUS? It looked like it was the mid-PDA.
Yeah, it was actually in right at the bifurcation of the PD-PL.
Okay. Is there any situation where you look at this and you say, I will preserve all branches, I might as well just stent?
Yeah. So, and I think we're going to find out a little bit more once the STAR registry data is published about kind of, that timeline of bringing folks back. Stenting up front, if you have great runoff, I don't necessarily think it's the worst idea. If a patient's traveled a far distance, it depends on kind of the situation.
Especially if you would have done it Stingray and you would have re-entered distal. Mm-hmm. And now you re-entered distal. What's the difference? It's the same thing, right?
Essentially, yeah.
To me, I think IVUS is very important to know if you're going to shear, if you're going to lose a branch or whatever.
And I had a very good sized hematoma down there in the distal belly of the RCA on IVUS. So sometimes, it's all in the subintimal space at that point. But to me, just let him heal and let him kind of recover from the insult from both hospitals at this point and see kind of how he does.
One of the things that we've been trying to work on in a more systematic way is understanding, so when these cases go subintimal and you're spiraling around, clearly you bounce off the proximal cap, and is there a way to identify where that cap is and re-puncture it? So I think that this is a great way to bail somebody out who's unstable or very symptomatic on the table. But one thing that we've been doing a lot lately is put the IVUS in to see if we can understand where the cap is, often with the dual lumen microcatheter on the same wire, so we can stab at what we think is the proximal cap, to have a second go at staying intraplaque and re-entering. And it's actually worked quite well. Obviously it's not going to work 100%, but it's another strategy before you go to STAR.
Yep.
Thank you. Sorry about that. No, so this is a great STAR case. If you go back a few slides and show us the appearance of the microcatheter. One more. And one more. One more slide, I think. Yeah, so that's fantastic. When you see that kind of wavelength and undulation, you know you're actually just spiraling around the outside. You're not going to be able to get in. Those are extremely difficult to stingray for a lot of different reasons. Even without a hematoma, you just can't align the stingray often in that situation. And one thing I've learned the hard way is that if your microcatheter tip is too close, now you're trying to STAR, the microcatheter itself is so stiff that it doesn't form the knuckle that the Mongo needs to. So what you did was fantastic, which you pull it back, and then so that way the wire doesn't take the same wavelength that the microcatheter did, and lets the Mongo do its own thing. So I think that's just something, a trick to induce STAR, because sometimes it can be very tough to get into that true lumen.
I think it's worth discussing something that we've submitted for publication, but I think there's two types of knuckle. We had a consensus paper on this, which is basically, this is a traveling knuckle. This is the whole wire that travels within the subintimal space, and I guess you want to discuss about that. But there's also what we call also rolling knuckles, which are typical, the ones that anchors proximal, and it's the full wire that dissects, right? So they're different, these ones. And here, I think the Mongo is a great choice for finishing, especially and to re-enter, whereas if you do a rolling knuckle, it usually will not re-enter because it just grows and grows and becomes, it's the stiffest body of the wire that dissects. So if it re-enters, it's typically because the tip of the wire that's anchored more proximal detaches, and then actually you have a sign that it re-enters. But here it's a great example of the value of a traveling knuckle, where it's the whole wire and its fold, and we call it, it's the sequence, it's catch, fold, and travel, versus the other one, rolling, is catch, coil, and roll, because you have to coil the wire. You don't coil the Mongo. The Mongo is, you just push it, you fold it, and then it goes forward. If you start rolling a Mongo, it becomes like a Pilot 200. And then you've lost the property of the traveling knuckle of this. So we're trying to make sense of this in a paper. Hopefully it will be published. If it's not where we send it first, going to be where we send it second and third. But hopefully we'll make sense of this. But tell us a bit what you had to say on this.
Yeah, no, so that's basically all the points. It's just a matter of understanding kind of what that knuckle is doing for you, and then before advancing any gear, if you have the ability to take a retrograde injection, it's just to confirm that you're not somewhere where you shouldn't be advancing a microcatheter into. But despite high initial success, STAR is used sparingly, and it's often used as a bailout or an investment strategy. And a lot of the issues that people will state against use of STAR is that there's an uncontrolled lumen reentry, you can lose side branches, and there can be high rates of restenosis if stented immediately. Again, though, that comes a lot down to what your outflow is. But newer evidence would show lower rate of cardiac death and MI. And I do think that some folks benefit from a strategy like this because we're getting them off the table sooner. So this is how it healed. This was about 10 weeks after that index procedure. He was feeling pretty good. And it was at this point I used a Xi'an and a microcatheter, switched out for a wiggle, and just did balloon dilatation and IVUS guided PCI. Ended up doing 3 stents coming back through to the proximal vessel. And that's how it all kind of healed up for him. But I think STAR is a very useful strategy, not only in the CTO space, but in non-CTO vessels too, if we run into difficulties of wire loss or dissected vessels. Technical success and complication rates are similar to other established techniques, but additional research is certainly underway, and the STAR registry will kind of help us maybe more so on when to bring these folks back, and if that range is actually longer or shorter than what we thought. But it can certainly be useful, like I said, vessel dissected and wire lost. Folks with have STEMI, large thrombus burden, don't have an experience with Stingray, but certainly if your options in CTO are high-end epicardials, this might be something that I would take on before taking on those sort of cases. I would just stress that avoidance of ad hoc CTO PCI would be something that I'm in favor of, and having an appropriate setup and plan for these sort of cases is what's critical to have a successful outcome.
Thank you, Rhian.
For a question.
I think we have to move on. Let's save questions if we have more time a bit later. Salman will give us the most difficult topic, which is 5.
It is very difficult. First of all, thank you very much. It's an honor to be here with a lot of these people are people that I learned from and who have inspired me in my practice. Having said that, let's go ahead. I do want to give you something to think about and maybe something new to try. I know there's a whole lot of new stuff, but this is hopefully new. Okay, where's the remote? Okay. All right, so this is a patient, 62-year-old man with known coronary disease, comes in with progressive angina. He's had prior bypass about 4 years ago. 4 years ago, outside the state, he had a lima to the LED, SV to the PDA. At that time, his circumflex was presumably doing okay. Multiple comorbidities, and he had progressive angina for about 3 months. And you can see that his physician who referred him to us had tried actually to treat the angina with medications. He did not have a stress test. What they did was actually a CTA. And based on the CTA, they found that the lima to LED was patent, the vein graft to the right was occluded, and there was a CTO in the LED segment. They also noted that the left main had an anomalous origin from the non-coronary cusp. So here's the angiogram. So I guess I'm just used to seeing the bigger screens. So here you can see that the right side is fairly large. The apex is probably supplied by this PDA. There's a lesion at the origin of that PDA, and you can see the multiple collaterals that are going up to this proximal LED segment there. And clearly you see this long diag that comes off of that. Here you see them trying to get into that anomalous left main. They finally managed to do it with what seems to be like a JL5 catheter. And here you can see a nice sort of little, oops, let me go back. Well, you saw it, there was a nice little cap there. And this is sort of another view. And here you can see that there's actually progression of disease in the circumflex, and you have a bifurcation lesion in that sort of ramus OM1. And then here's a picture of the graft, somewhat slow flow. I don't know if there was air before that, but I don't know, it's funny looking flow there. But anyway, it does go down to the very distal LAD, and you can see the LAD does not supply the apex, confirms that the apex is actually being supplied by the PDA. So really the challenge at this point for my colleagues is, where is the ischemia coming from? What would you do next? What to tackle first, native disease versus CTO? Presumably, if you fix that circumflex, maybe the patient might do fine. And if you were to do a CTO PCI strategy, what are some of the pros and cons? You've got the anomalous left main, you've got the wide aortic root, you've got a short CTO segment, which is favorable. Calcified native artery. On the CT, they said it was moderately calcified. What are the retrograde options? And I'm just going to throw this in there. Here are some of the options as I saw them. Green is relatively straightforward, which I think a lot of us would start by attempting. Red is perhaps, reasonable, that route. And yellow are the sort of Cambis collaterals. We don't do those. We don't even talk about those. That's prohibitive for me. But anyway, so with that, I'd like to turn it to you guys and see what you would do.
Any thoughts?
So here it looks like if you fix the LED, you may have to come back to left main, which may make the circ intervention, ramus intervention a little bit harder. So I would, and looks like there is a landing zone in the circ, so I'll probably just fix the circ first and then do the LED afterwards.
That gets to what I was going to ask. Like, where's the ischemia coming from and what actually needs to be fixed here? That's what I'm struggling with from your presentation.
It was a struggle for me too.
I wonder if doing a dual diagnostic angiogram might help you a little bit, just throwing in a radial sheath in the left radial and seeing, because I don't understand how much of the LAD in the middle are we missing? And I think maybe that might help.
I think that's a great idea. So I should have told you this earlier. This is not my angiogram. This was done by the referring physician, who thankfully did not attempt it. And so that's what I would have done, right? So I've told my referring physicians who sent me CTOs on a regular basis, at the very least, before you send them, do the dual injection. Many of them started doing them. So even those who don't do CTOs will often do a dual injection, then send the patient to me, which we're very grateful for.
Really?
Yeah, so a couple of them. They want to do CTO someday maybe, but anyway. So what we do at UT, we have a big sort of PET lab. So we do a lot of PETs sort of evaluation. And so Lance Gould, and he's done a lot of work on this. And so for me, the answer where the scheme is coming out is a PET. So that's kind of my deal. Patients are like, why do we need another stress test? I'm like, well, this is how I do it if you want me to do this. So we sent him for a PET. And interestingly, that PDA was not very significant. In fact, the anterior wall looked quite good in the sort of distal segment. All of the ischemia was in the basal and mid-anterior wall and the anterolateral wall. So it kind of argues for fixing that LED and perhaps that circumflex and not doing anything to the RCA. Okay, so how did we approach it? Now, this is a long case. I won't go through all of this, but here's a 7 French EBU something, an EBU4 guide, and we fixed that sort of proximal circumflex, and actually it ended up being a fairly sizable vessel, and we ended up doing culotte here. So you can see we fixed the stem in the ramus and the circumflex and got a fairly decent result. In terms of staging this procedure, I think this would have been a reasonable place to stop and stage it. And so the next question is, how do you attempt the LAD CTO? And so before you answer, I'm just going to leave you these dual injection sort of angios that you had asked for. What would be your approach to the CTO? Short CTO.
On this view, it's difficult to see, but on the previous attempt, you could see the LED is non-ambiguous at all, right? Here, you don't see anything leading in this view, but in your previous, when you fixed the circ, you could see to take off the LED, you know, that previous one, it's like, it's right there, right?
Yeah, so it's not ambiguous. I'll play it for you. You can see the little, there you go. It's just overlapped in that view, so.
I feel like this location, though, this osteoproximal LAD, I don't trust it. It's always longer and more tortuous than you think it should be on the angiogram. So I would say wire it, but I think that might end up being real hard.
So
you had a CT. I mean, how did the course of the LAD look on the CT prior to this? If there was a concern about that, I think it would be a good idea to
It was relatively straight. It was relatively straight, but they said there was moderate calcification, and they said, you know, they call it subtotal to total, but as I'll show you, we probed it with the wire, it wasn't a subtotal.
If I recall, there was no retrograde filling whatsoever from the Lima injection, right?
None whatsoever. Okay. None whatsoever. You're right. Absolutely right. And even if there was, I think that's become such a tricky angle to come back that distal of a Lima. Okay, so this is where we're going to deviate from the norm. So I'm going to show you something that I'm not sure a lot of you have seen before. You might have. I might be wrong. But so there's antegrade wire escalation. There's antegrade dissection reentry. There's retrograde options. And then there's what we did. And this is what. And I feel this is why Manas wanted me to present this. So something different. So the first thing we did was we actually went ahead and punctured the cap. So you can see there's a turnpike LP in there. We tried to probe it with a Mongo wire to see if the wire would travel, and you can kind of see that the wire was pushing the. So we then took a Gaia 2 and we kind of scratched into the cap, and I just went for about 2 or 3 millimeters. And then I rolled the microcatheter into that cap. So you've got a microcatheter that's now just crossed the proximal cap. And this is where you would probably switch out for a Mongo or something like that and see if you can cross in sort of antegrade wire escalation or some other polymer jacketed wire. But instead of doing that, we did something different. So first of all, we changed our angle at that point because now I wanted to optimize my view for something that I would be able to get into. And as Monty Python would say, and now for something different, well, this is different. So we then injected contrast. And we injected contrast upfront, about half a cc. And we'll talk about the rationale for this. This is called the modified Carlino technique. It's modified for several reasons. A, you're not deep. So with typical Carlino, you kind of push with the wire where the wire stops or can't go. That's when you Carlino. This is an elective upfront Carlino. The second modification is you don't do it distal, you do it proximal at the cap. You cross the cap 2 millimeters, you inject, right? The third modification is you use a very small amount of contrast, which is about half, ml, maybe 1 ml. And the last modification is it's a very gentle injection. You do it very, very gently and kind of see what happens to the contrast. You let the contrast sort of negotiate this way with the blood vessel and see what's going on. So we see 3 different sort of stains here, and one of them looks a little concerning because that may or may not be a perforation. So what are these stains? All right, so stain number 1 is a branch that you did not see before. That's a diag that you did not see on any of the diagnostic angiograms. Stain number 2, which showed up next, was actually a septal. And stain number 3 is actually the distal cap. You can't tell it right now, but if you go back and see, you saw some flash at the distal thing. And so that was competitive flow. So actually, this is a very short CTO, not as long as you would have thought. But in between all those stains, you have this sort of blank zone where you don't see anything. And the question is, what's really going on there? And we'll talk about that a bit. Okay, good. So you go ahead, and we wanted to confirm that we were indeed, that was a distal. And now you can see that not only do you have, so you see the distal cap, its morphology or its anatomy matches of what you did antegrade. You see how short the CTO actually is. And you also see that there's some retrograde competitive flow, so you've actually made a channel. So whatever that contrast injection was, that modified Carlino actually did do the trick. At this point, which wire do you use to cross? And here's the other sort of really cool thing, which hopefully you will enjoy, is this is a Fielder XDR, but there's absolutely no tip. Fielder XDR comes out of the packet, I flush it, and I put it in. And what I'm actually doing is I'm injecting retrograde, I'm letting the Fielder XDR find its own way. And the Fielder XDR tracks along that track in that sort of blank space, goes into the distal cap, finds that diag, and just goes down it. I'm not pushing hard, I'm just gently letting it do its thing. The whole time from engaging that cap to this was under 5 minutes. 2 wires. So then there's a microcatheter going across, Turnpike LP. At that point, again, I was pretty confident in true lumen. Sometimes we'll, transduce pressure. You can do that also. We did a distal tip injection, redirected it, did a tip injection. And to your point, there is Allison, some competitive flow from that LED. The lima, you can see that, but really not a whole lot. There's probably disease there. And then this is our final completion angiogram for the LED. And so what's impressive here is, A, that obviously everything is open. B, that septal that appeared is still there. And even that diagonal, now that diagonal has sort of shut down a bit, but you can see the other major diagonal, we were able to save that. So we were able to preserve a lot of the branches that supply the septum. So that's really also fantastic, because typically when you go through plaque like this, even with antegrade wire escalation, you don't always get those side branches. And this becomes important when you're treating something like that RCA we talked about, and you preserve those right ventricular branches. So any comments before I go on?
Go ahead.
Okay, let me finish and then we can talk. Okay, so this term is not mine. I just call it a modified Carlino, but Carlino calls this hydrodynamic contrast recanalization. It's a mouthful. We all call it HDR. Friends call it HDR. So it's a novel CTO crossing strategy with 2 essential components: intraplaque injection of contrast, which must be done very gently and very proximally. It's done before the wire stops. So even though your wire may want to go, that stiff wire, you stop, you inject in the proximal cap. And B, you use small angled, tip angles with hydrophilic wires, and just gently, there's low weight wires. You see where the wire goes, if it follows the contrast or not. And the upshot is that in the standard technique, the wire leads the way. In HDR, contrast leads the way. And just the way for wire in standard issue is, you trust the knuckle. Well, those of us who do HDR, which is just me and Mauro and a few other guys, is you trust the contrast. Provocative, I know, but hopefully this is something you guys would try in your own practices. How does it actually work? This cartoon actually was done by my daughter. She was really good at this. This is how I think it works. I think that when you start injecting contrast, it goes into the softer portions of plaque, if there are any soft portions. That's why it doesn't work in very heavily calcified vessels. But it tracks along and creates channels that then break into one of 2 things. Either the channel breaks distally into true lumen, that's what we call type 2A, or it breaks to a side branch, and you can see multiple side branches appearing. These are different cases. That's type 2B. Sometimes the channel doesn't go anywhere. So in type 1, which you see just below there, what you actually see is that the contrast starts accumulating and starts coming back towards the microcatheter. When it's coming back towards the microcatheter, that means you're in the adventitial space, and now you're doing retrograde. So early on when we were doing this, I've done over 200 of these. So but when we're doing this, we found that actually that was the beginning of a retrograde or intramural hematoma. So we don't let it get that far, but that's what all of these patterns represent. And so we've done some IVUS studies. Now this case, I wish I would have done IVUS if I'd known I was presenting here, but you never know that. This is another RCA CTO, and what I want to show you is that,
Salman, I'm sorry, because the people are really leaving, so maybe we just close it in a minute because we have
yes,
the next session.
Okay, so we'll make it quick. So the bottom line is those yellow arrows, I think that's what the contrast does. That's actually just microfenestrations of this plaque caused by this plaque. So ultimately, key learning points: HDR is novel antegrade crossing technique. Obviously, it needs to be proved. HDR utilizes gentle intraplaque contrast injections upfront. It differs from prior iterations of Carlino method in several important ways. And finally, it may be a paradigm shift in how we can use contrast during CTO PCI. That's it.
Thank you very much, Salman. Just maybe one question.
Are you doing this in every case? And if not, what biases your decision to do this or not?
Every case that I can puncture the cap, I'm doing it. And after having done about 200 cases, I would say that this HDR mechanism works about 40% of the time. But that's 40% of cases that are then crossed under 10 minutes. The rest are your usual antegrade wire escalation, knuckling, star, retrograde. You can do this retrograde also. It's great for opening up those retrograde, those occluded grafts. So multiple applications, but I'm really hoping that people here, especially you guys, will do this and then add to the data, because that's what we need to do.
All right, thank you very much, everybody. Enjoy the break.